if you come to these talks, you're going to see how I have fundamentally transformed the way I practice cardiology because of AI. So I spend all of my time developing, validating, and deploying AI technologies in the space. This technology is not where it was 2 years ago. And I can tell you that the impact on my own clinical practice has been really, really significant. For me, this all started a couple of years ago when I was staffing the cardiac ICU overnight, and I got a call from an outside ED about a 62-year-old gentleman who had shown up in this emergency room 3 months prior with chest tightness and shortness of breath. They ruled him out for an MI, and they said, hey, the only thing we notice is we hear a murmur on exam. You should go see your primary care doctor, but you're not having a heart attack. You otherwise seem to be doing fine. Life got busy. He didn't get to a primary care appointment. Then he had another episode of the same thing, chest tightness, shortness of breath. He goes back to that same emergency department. This time, though, he's in respiratory distress. He gets put on a ventilator and goes to the ICU. They do an ultrasound of his heart overnight and find out that he has critical aortic stenosis. I work at Columbia University, which is a world-leading valve center, and they say, hey, we want to send him to you immediately. I said, absolutely. I spent the rest of the night working on him. By the morning, I put him on ECMO. He had an Impella in place. He was on CVVH, and he died later that week. If we had just known about his aortic stenosis, I think he could have gotten a same-day outpatient procedure, and I think he'd be alive today. And it really hammered home one of the real challenges in medicine that we all face, regardless if you're practicing, if you are researching. You can't treat the patient you don't know about. And we have to be thinking of new care paradigms that get the patient to the right diagnosis, the right treatment, the right provider at the right time, and fights through all of the unique challenges that we face in care equity, cost effectiveness to get there. And that's where I think AI can make a real difference. So my group of around 16 data scientists, data engineers, clinical trial coordinators, and clinicians, we develop, validate, and deploy AI technologies, particularly around the cardiac space. Okay, so where does deep learning actually make a difference? I think there's a couple of data set domains where machine learning, deep learning, artificial intelligence, the real crux of the new stuff that's come out in the last 2 to 4 years that we're all talking about, where does it actually make a difference? So I think it's imaging and complex language. So to date, when we look at medical imaging, all we have is we have human interpretation. And the occipital lobe is an amazing pattern recognition device, but it is flawed. And all I have to do to prove that to you is tell you that all of the gray lines running horizontal in that image are parallel to one another, even though your brain is telling you they are not. We have an incredible pattern recognition device, but it is flawed. For the first time in human history, we have an alternative pattern recognition device of a similar level of sophistication as the human brain that is able to uniquely interpret images. That is why it is so impactful and it's been so game-changing for medical imaging. Secondarily is complex language. So that's another place where we have a huge amount of data being left on the table. And as we know, one good note is better than 500 garbage ones. And so I think that's where you're seeing a lot of the non-deterministic generative models like LLMs potentially have the ability to for significant impact. So imaging and complex language, that's the places where it's going to be. Don't be building an XGBoost model on a bunch of prescribed data that's in the electronic health record, because a logistic regression model would get you 95% of the way there. And the real issues there are workflow. And using a machine learning model is going to make it just harder for whatever you're building to get out there in the real world. So a lot of AI papers for the last 4 to 5 years have looked like this. I'm trying to build an AI model to predict pneumonia from chest x-ray. And the current best AI model is 70% as accurate as the human experts. And then I built a new AI model, and it's 80% as accurate as the human experts. So the human expert interpretation is your gold standard, and the goal is for your new model to get closer to the expert than the old model. We flip this on its head. We think some of the most important questions that AI can answer are ones that doctors are not experts in. Instead, our label, the thing that we learn from, is a more accurate but more expensive downstream diagnostic test. And then we ask ourselves, can the AI model look at the cheap test and predict the more expensive test better than a doctor can, and thus exceed human performance, not try and catch up to it? So here's an example of it. One of the first things that we did is we asked ourselves, can we detect significant amounts of valvular heart disease from an electrocardiogram? So every single one of us who went to medical school or did cardiology fellowship was taught you cannot detect severe aortic stenosis or aortic regurgitation from an electrocardiogram. But we asked ourselves, could an AI model do exactly that? And it turns out that you can train these AI models to detect with a relatively high degree of accuracy aortic stenosis, aortic regurgitation, mitral regurgitation, significant amounts of valvular heart disease, and distinguish those patients. And this was one of our first landmark papers in JACC back in 2021 or 2022. What we realized is if we were really going to go on this journey, we had to build the data. So we've built the largest cardiovascular database in the country. It's now 13 million electrocardiograms, nearing 2 million echocardiograms, 8 hospitals, 190 clinical sites, 6 echo labs that all use different reading software and can agree with one another in any way about, oh, should we use Teicholz for ejection fraction or this or that? But what we've done is we've actually gone through, we've sanitized, tokenized, and clinically validated all of that data to create a single harmonized table where all of that exists. That means I can go and say, this is the general truth. I know every patient who is diagnosed with severe aortic stenosis going back to 2008. I have every electrocardiogram going back to 1985. We are able to look at these patients from a racially, ethnically, payer mix diverse standpoint across a huge range of institutions, academic, tertiary care, community hospital. This was our first paper, our first landmark paper, I should say, about ValveNet, where we said, yeah, we actually can detect valve disease from ECGs. But we knew we wanted to actually go put our money where our mouth is. We wanted to test this out in the real world. Can this help people? That's what this was always about. So this is still how we recruit for clinical trials today. I think at most places, this is literally the elevator bank outside of my office at Columbia. You know, this one on the left is a perfect example. Are you 18 or older? No recent x-rays? Can I pay you $20 and do stuff to you? This is not a scalable, effective, or equitable way to conduct clinical trials research. And so we realized we had to completely turn the clinical trials infrastructure on its head. So what we've done is we've created a real-time recruitment platform for clinical trials and clinical deployment. This is instant AI deployment at 8 hospitals and 190 clinical sites. So what happens is as soon as any data across any of our vendors and across any of our modalities is created, it's automatically sent to our cloud platform. A copy is kept for research. A copy is run inference on. We have run inference live on over 1 million patients in the last 2 years and delivered those results to clinical trial coordinators, clinicians, and researchers. And we have numerous ongoing clinical trials. By the way, you don't need to make this stuff fancy. When we first started doing this, I said, I'm not going anywhere near Epic, our electronic health record. This is an insight and it goes to your inbox first thing in the morning. You know what to do, go for it, right? And over time, we now have full integration into Epic. We have alerts, we have this, we have that. You can build out the bells and whistles, but if you know something is a real problem, you wanna go out and test it, don't let other people tell you no. You can make it work. So if you take nothing else away from any of my talks, this is the most important slide, okay? Because this is what really is going to dictate the impact in the future of artificial intelligence for our field. Bob Wachter is my mentor from UCSF. He's the chair of medicine there. Eric Brynjolfsson is an economist we both have a huge amount of respect for. He wrote The Second Machine Age when he was at MIT. He's now at Stanford. Eric has spent his career studying this thing called the IT paradox. There is some industry and IT comes to it, and everyone expects significant productivity gains in that economic sector, into that field when IT comes. It like makes a lot of sense and all of that. IT comes, and then there isn't a productivity boost. And why is that? And this has been true for industry after industry after industry. He has distilled it down to this idea of the 2 key hypothesis, and this was a paper they had in JAMA. There are 2 things that have to be true to unlock productivity gains. First, the technology has to be sufficiently better than what exists today. I can tell you confidently that there are numerous places where the utilization of AI is significantly better than what we do today. That key is already unlocked. It is the second key that will make all the difference for our field. We have to reimagine the work itself. We have to reimagine what it means to be a doctor, a nurse, a care provider, a health system, electronics vendor. All of that has to change. We have to reimagine the work itself. What it means to be a software engineer from 20 years ago, from 10 years ago, from 5 years ago, is hugely different. And that is dizzying, but that is the unlock for productivity. So I am practicing cardiology in a way that I was not 5 years ago. And it is uncomfortable. And I am trying to navigate it for myself as well as my institution, where I'm the medical director for AI. But it is important for us to be able to help as many patients as possible and change the way that we practice. So here is the foundational question I've spent the last 5 years thinking about. Of all the people with the cheap test, who needs the expensive test? Can I create a cardiovascular screening test? And what I mean by that is we have mammogram, we have colonoscopy, we have no equivalent for the vast majority of cardiovascular diseases. Can we find a way to detect disease earlier? And can we use the cheap test that's been around for 120 years to do it? So we built EchoNext. This is a single model that makes predictions for LV dysfunction, RV dysfunction, moderate to severe valve disease, severe left ventricular hypertrophy leading to cardiac amyloidosis, pulmonary hypertension, and pericardial effusion. Really, all of the things that if I told any of the clinicians in the room, I think one of these things is true about the patient and they don't have an echo, everyone agrees what the next step is: get an echo. I am proud to announce as of this week, this paper has been accepted at Nature and is going to be coming out in 4 weeks. It took us a really long time to put this study together. It took us a really long time to get a paper into Nature. I don't know if I'm going to be submitting anything to Nature anytime soon. But we have validated this technology at 11 hospitals, 4 health systems in 2 countries. And we did a couple of things. So we ran the model in the background for 90 or 85,000 patients, and we followed those patients for a year. These are all patients who were getting an EKG as part of routine clinical care and had no prior echocardiogram. And we followed the patients and we asked ourselves, what happens if we just monitor those patients that were predicted as high risk by EchoNext, our AI model? So what you can see is that it predicted 9% of all those patients as high risk. Half of those patients go on to get an echocardiogram, and the half that get an echocardiogram, their positive predictive value is 74%. Just to give you an idea, if you look at all first-time echoes being done at our health system, the baseline positive predictive value is 36%. So right off the bat, the AI model has doubled the positive predictive value in those patients who are going on to get echocardiograms. The smoking gun evidence was half of the high-risk patients don't go on to get an echocardiogram. If I told you that half of the patients with heart failure who were showing up to your health system weren't getting a diagnosis, I think you'd be alarmed. And this was true across 8 hospitals. We then recruited 100 patients who weren't otherwise getting an echocardiogram, and we brought them in for an echo. And we saw the very same positive predictive value, 72.7% in the high-risk group, 28% in moderate risk, low risk, 5.9%. And then this was presented at TCT earlier this year. Lastly, we asked 13 cardiologists. These are the cardiologists who I send my loved ones to look at 3,200 ECGs. And they looked at half the ECGs with the AI model, half the ECGs without the AI model. And then we asked them, hey, do you think this patient has structural heart disease or not? So the cardiologist baseline performance was accuracy of 64%. We then gave them the AI model and went up to 68%. The AI model alone was 78%. So every one of you in here who is not a cardiologist would do better than I would. So we're really starting to see that promise of AI models not catching up to the clinicians, but potentially exceeding them in certain tasks. Okay, maybe it's just the cardiologists. We're a very arrogant bunch. Maybe the radiologists are going to do better. So this was our work that was in European Heart Journal earlier this year. So we said, well, can we use a chest x-ray to try and detect earlier stages of heart failure? So many of you know the majority of patients get diagnosed with heart failure in what's called stage C, which is once they're symptomatic. But we asked ourselves, could we diagnose patients in stage B, which is when the heart thickens and dilates, when we have left ventricular remodeling? And could we use a cheap test to figure out the patients who have stage B heart failure? So we built an AI model to look at a chest x-ray and try and detect severe left ventricular hypertrophy or a dilated left ventricle. We trained this at Columbia. We validated this at Stanford. It outperformed all 15 radiologists we asked to go head-to-head. So this was the first time that an AI model had ever outperformed radiologists in the detection of some cardiac pathology. And we've made this data, by the way, completely freely available on PhysioNet, all 85,000 chest x-rays. Someone go build a better model than I did. One of you is out there. So I'm going to stop there. I think that's the discovery part. And then I think in a half hour from now, we're going to start talking about the diagnosis. What happens next for these patients?